Hey everybody, it's Karen Anderson here with Aortic Hope for tonight's Ask a Doctor event. So usually I have another co-host with me. I don't know really what happened to her, but that's all right. She will either join later or she'll be with us the next time we do this. But what the Ask a Doctor event is, it actually takes place on Facebook. So for those of you that are part of Facebook, in about 15 seconds or so, I keep refreshing my screen. It is up now. You will see a post with Dr. Prakash. It says Ask a Doctor, and that is where we're taking questions. So you can type your questions in there, like I'm about to start the questions right now. And you can also type questions here in the comments section, and I will be typing them into Facebook and relaying all answers to questions here. So yeah, we're kind of simulcasting, right? Isn't that what we're doing, Josh? Yeah, that's what we're doing.
Almost. It's almost simulcasting.
Yeah, so
Hi, Bryce
let's
Redeman.
see. Hey, how are you?
Hi,
I
Donna.
was hoping that you would join. Go ahead and start typing in some questions. Nice to see you. I can't really see you, but I'm being told that you're here, which is great. So when you're on here on YouTube, please do me a favor, click like, click subscribe, click the bell so you're notified when we have live events like this, because we have another live event. It's one of our Q&As tomorrow night at 7 p.m. Eastern with Dr. Kyle Udaly. And it's his first time joining us. So yeah, that should be interesting. We have a lot of aortic related questions to ask him. This is really interesting. I wonder if playing a musical instrument and singing is kind of like talking and trying to type. Because it's challenging. Yeah. Yeah, so we're just typing a couple questions that have come in from the community. Okay. You're going to see them popping up for those of you that are on Facebook right now. So many interesting questions. You know, we are seeing a lot of questions come out in the community about allergies, about taking cold medicines or decongestants, antihistamines. Like, what can we take? What can't we take? Because I'm sure all of you know that a lot of these can be a little bit of a stimulant and increase your blood pressure and heart rate. So I'm curious to see what we're allowed to take when you have an allergy issue. Let's see. Uh, okay, and the other things that we're seeing would be questions about exercise. Always we get this question all year round, but particularly during these warmer months, what does that look like for people? Whether you're in watch and wait or post-surgical, right? That's pretty interesting. And let's see. What else? We see a lot of things in the community talking about what actually is considered an aneurysm. That's always interesting because we see a lot of people becoming very alarmed when they're told they have a measurement of 39 millimeters or 3.9 centimeters. And really, what is that role? Now, I know when we've had Dr. Ben Udelman on with us before, he's explained that it has a lot to do with the width of a thumb. But, you know, my thumb's going to be smaller than somebody else's thumb. So maybe my thumb is the only thing that pertains to my body. I don't know. I'm thinking that's how it works. It sounds good, right? I think it sounds good. Let's see. Dehydration, like how easy it is for dehydration to happen and how quickly can you rehydrate your body.
Bryce added this to chat. I added it to chat for you, but I also put it in the anonymous form.
Okay.
So.
I know you guys hear me click clock, click clock. This is my like favorite keyboard of this year. Okay, so I'm gonna go pull up a question that came in from a community member. I'm gonna get my cursor down to the other screen because I'm now triple doing things at the same time. And I'm gonna refresh and we're gonna see where we are with Dr. Prakash answering questions. So I'll be doing relaying here for about an hour and then he'll still be taking questions on Facebook. So waiting for my chat to come up. Let's see. Okay, hang on here. Yeah, gonna have a problem with the mouse. This is gonna be fun. Here we go. Okay. What you got going on there, Josh?
Well, I won the 4 o'clock Rocket League tournament. That was drop shot this afternoon. That was
What does
awesome.
that mean?
Highlight of my day.
What's that mean? Rocket something.
Oh, Rocket League. It's my stress relief.
Okay.
Bryce redacted his message. Bryce.
What happened?
I don't know. I put it in chat for you.
Oh, I have it. I'm
Yeah.
totally looking at it right
But
now.
it
Yeah,
just
I
says
got it.
that he redacted it.
Hmm.
Bryce, what are you doing
Alright.
to us, man?
Technical difficulties already? Okay. All right. Let's see. Let's see where we are with answers coming in because sometimes doctors run a little late because they do have an important job. They don't need to be on time like me. And let's talk about my punctuality. Okay. This is a result of going to the pool today. Okay. Coming home, cleaning out my office, like really cleaning it, and then talking on the telephone and getting sidetracked. So when I looked at the clock, I realized I had 10 minutes till I had to come on and do soundtrack. So this just kind of looks like it's put together. It's not put together. That's all right, right? That's all right. Okay, how are we
It's
doing on
totally put
responses
together.
here? I do? Well, that's good. 24, let's see. All questions, comments. Let's see
Oh,
what we've
he
got.
put it in the anonymous form. Thank you, Bryce.
Following direction. That's wonderful. Okay. We are still waiting for responses from the doctor. So as you guys that are watching here, if you have questions, please let me know so I can start asking them. Okay. All right. So the doctor has been notified that we are live, we are going, we are strong, and just waiting for some additional questions. So yeah, I'm really interested in this whole how the weather impacts. I know Dr. Fisher did a great job of explaining how your vessels contract or expand in different weather. So we're going to talk about that a little bit more. I see that there's been an answer because I hear the ding. Let's see what we've got here. Let's read the question and get to the answer. All right. As my page is refreshing. Okay. Let us see which one was answered. All right. Okay, it was hi everyone. That's what it was. It wasn't answering your question. He's so cute. He just said hi. Okay, so we've got a hi. We're making progress. This is good. We're going to start getting some answers in now. Yeah, so I am curious again about the heat. It's been like cool and then it's been raining and now it's been hot and what's the best way to manage that? Because I think you can get dehydrated pretty quickly and also when we're taking a lot of medication uh, because we have a high heart rate or high blood pressure, and this medication is suppressing our heart rate, are we doing any damage when trying to force that rate to go up when exercise? Okay, I'm going to ask that question. Let's see. I like asking a lot of questions that are on my mind because I know they're on your mind too, but they're on my mind. So I'm going to ask when someone is taking a lot of medication, are we negatively impacting our bodies? Okay. We've gotten another question. Do we know of a good hospital to go to for ascending aortic aneurysm in North Carolina? That's great. Any aortic centers in North Carolina for monitoring
Are you
and
are
ascending?
you typing these?
I am.
You know you can
I
copy and
know, but
paste.
it was all caps. I don't want to do all
Oh,
caps. I
oh,
got to,
oh, oh.
yeah. Okay, so discuss the infection when it comes to our. Oh, that's a really good question.
That is from Tim
Um,
O.
yeah, that's a great question. Okay. Can we discuss the infection when it comes to artificial valves? Bacterial infection versus viral. Is there big or little staph infection versus a hangnail? I'm okay. Well, that one I'll copy. Let's see. I'm having my mouse is cute looking and not acting cute this evening. I can't get it to go to the next screen. Having like this is a problem. This is causing me stress. There it is. Okay. Let's put that in and let's refresh the screen and see what answers we got. Okay. Answers are coming. These are good questions, you guys. Bring them in. Uh, Otherwise, I'm trapping all of you to listen to the questions of my life, which I actually tend to do quite often, only because I know you're interested. But this is the stuff that goes into my brain 24 hours a day. Good times. All right. We're getting some answers now. Let's see what we've got. Do. All right. Um, okay. Loading. That's a good sign, right? So there was a question about why do different diagnostic tests yield different results? That's important because we do see that all the time. And the interesting thing is, I think to a lot of us, we think that if you have an echo and it says you have an aneurysm at 4.3, and then you come back from a CT and it says, oh, no, it's 4.5, we actually think it sounds like it's a big difference and it's a negligible difference. It really isn't. But his answer is diagnostic tests are designed to look for different things and therefore may be interpreted differently. In images of the heart and the aorta, it is not unusual for two cardiologists to measure the aorta slightly differently. That can lead to different aortic sizes on the test report. And one of the rules that it's taken me 9 years to really implement is I don't necessarily go by the report that the radiologist gives, because I have learned that my surgeon will actually pull those scans up himself and will measure them the same exact way in the same exact location, scan after scan after scan. So I leave it to him to tell me if there's been a change or if there's been growth. And I kind of like that. Then I don't get us freaked out. You know what I mean? I don't need to be, because if the doctor isn't, then why would I be, right? So that might be one thing to help curb the confusion that happens with results. Okay, I think we might have another answer. Let's see. I'm finding that I need to fill the air. We're not going to do that. All right, let's go. We have got another answer, and it's to the question. Let me see. All right, so that one was diagnostic. Okay. Do you receive different care when you see a vascular doctor versus a vascular surgeon? And the answer is most vascular doctors are actually surgeons. So there you go. So you're not getting any different care there. But that's a valid question. I'd want to know. I think that's valid. Oh, gosh. All right. Let's see. All right. So another question. I've asked the one about the infection. So let's go for another one. All right. Let's ask. I'm trying to think of some of the questions that really get people kind of inflamed in the community and it starts just a downward spiral. Let's talk about, let us talk about uh, ablations. No, I already have that as a question. Let's talk about managing your uh, sodium intake during the hotter months. Um, is there a best practice? Okay. Um, what other things have we seen? There's so many that it's like, why is it escaping me now? I have no idea. But that's all right. We've just got another answer to another question. Let us see. glad we're able to address this in both places. It's kind of nice. Okay. Do. Need to refresh the page. We've just got two more things that have come in. Let's see. I get really frustrated when I see answers to questions that involve making medication suggestions. That kind of frustrates me. Number one, we're not in charge of changing our medications. Number two, why would you tell anybody to change their medication? We're not physicians. So I think what's better is share with people which drug in that specific classification you might be taking, because we know that typically we just had a lesson on this on Topic Tuesday last week about beta blockers, the LOLs, LOL. We talked about these beta blockers, and there really are so many different types, not different types, but different medications in that category. And we typically see ourselves being prescribed metoprolol when you're in the hospital. And then that turns into labetalol when you are discharged. And a lot of people complain that there's just this fogginess, there's a confusion, a short-term memory issue. It gets mixed up with pump head, et cetera. But that doesn't mean that's the only drug you have to take, because there's nebivolol, there's carvedilol, I think is how it's pronounced. And it doesn't mean that whatever your reaction is, fogginess, lack of energy, doesn't mean that that's going to happen when you try a different drug in the same classification. I know this firsthand. This is the experience I'm sharing with you to be able to advocate for yourself and ask the questions of your physician. So maybe if you're feeling that way, talk to your doctor about, is there anything else I can take? Because this is how I've been feeling for a long period of time. So that's what I would recommend. Okay, what's a calcium score? I had no idea. Who needs the test, and how often do you actually need to be tested? I asked this one time because my husband had one, and I thought, well, gosh, it would be the only test I haven't had so far in my life. And I was told I didn't need it because I have a cardiac MRI. It actually shows the potential for plaque, calcium, stuff like that, plaque buildup. So a calcium score measures the actual plaque buildup in your heart arteries. And it's a common screening test to actually look for coronary artery disease. So it's looking at the coronary arteries. Anyone with risk factors such as a family history of heart attacks, high cholesterol, smoking, or high blood pressure may be referred to have a calcium score test, get a calcium scan. It is like a CT MRI type of scan, CT type of scan. I think it's MRI, but it's one of them. I don't remember, but it's non-invasive. And it really tells the physician a lot. It's a lot easier to do that than to go and have a cardiac catheterization to determine what's going on. It's nothing. It's from the outside looking in. And one of the things I learned about this, which I was so fascinated, is that people who are runners, marathon runners, actually tend to have really high calcium scores. But there's a whole thing about what that calcium makeup actually it is, and why in their case having a high score isn't necessarily considered life-threatening or dangerous. That's so weird to me, but just thought I'd mention that. All right, here's another question. AFib. AFib is an arrhythmia. All arrhythmias are annoying, so it doesn't matter. But did you know that like almost 2 million Americans have AFib, and the majority do not feel anything? They wouldn't know unless their Apple Watch or watch starts beeping, telling them. But some people do feel it. And the most common, uh, uh, what is it? What's the word? Word just escaped me. The most common sensation that one would feel would be fatigue. So I think there's this misconception that AFib is instantaneous rapid heartbeat. It could also that can it's not it's the way that your rhythm is. I think it can show in rapid or show in decreased heart rate. So AFib is very common after any type of cardiovascular procedure, such as an aortic operation. Inflammation around the heart can occur after surgery or can occur after a dissection, and it's the most typical trigger for AFib. I don't know how soon after these procedures would you experience it, but that's a common reason and a common cause. It is okay to have an ablation. If you've tried medication and you've tried lifestyle changes and this is what your next step might be, it's okay to have an ablation after you've had a dissection if you need it to help fix AFib. Typically, people with AFib do have to be treated, though, with a strong blood thinner like Eliquis, and that's to prevent strokes because it can cause clots to build up inside the heart. And that's because there's a funky heart rhythm that's happening. And it's too much to explain. It's been explained to me and it went over my head. I just like knowing that if I've shown signs of it, if I'm on Eliquis, I'm being protected from the worst outcome of having AFib. It's annoying, yes. But if you're somebody who's suffering from it, like 24 hours a day or having long bouts, and this is what's being suggested to you, then you should really watch a video, learn a lot about it because it is common and it is okay to do after a dissection. Just letting you know. Okay. But is open heart surgery the only way to fix an ascending aortic aneurysm? It's not the only way, but it is for 99% of ascending aortic aneurysms. It is the preferred way. It really is. In rare cases, a stent can be placed in the aortic arch or the end of the ascending aorta to stabilize an aneurysm or dissection, but it is typically preferred and most often open heart surgery is the way you're going to go to have that ascending aortic aneurysm fixed. Okay, let's go and ask some more questions here. Okay. That's a really good question. Curious to know how many physicians actually send their patients to receive mental health therapy uh, after a diagnosis. Like that's a great question. If I could get, oh, there it is. I almost had my, it's this mouse. It's getting it to jump from one screen to another. Okay. Let's see. Okay, so do you ever send or refer your patients to a mental health doctor when you find an aneurysm? All right, and there was another question. Okay. Great questions, everybody. Keep them coming because he is on a roll answering now. All right, we're going to refresh the screen and see what else we have. Huh. Okay. I was always curious about that AFib because you do see a lot of people in the community that talk about it. I assumed they went hand in hand, but I wasn't 100% sure. So while we're waiting to see if there's more answers, I'm going to do like station identification, product placement.
Promos.
Promo. Look at that. This is the aortic disease awareness ribbon in the form of a car magnet. This is awesome. And this can be yours with a $10 donation, international or domestic. This is on our Hope Shops page. Swag order form. You can choose to order one of these or more than one of these. This has, I can't tell you how many people have actually stopped me when I've had this on my car. I just changed cars, and they wanted to know they'd never seen a ribbon designed like this. Something to think about. Okay, comments. Let's go back to the comments. Let's see what we got here. All comments. And let's go. All right. I think I got a lot of chlorine in my eyes today. Okay. Nope, that one wasn't answered yet. That one was. Talked about that one. Any aortic centers in North Carolina for monitoring an ascending aneurysm? You can go to marfan.org. The patient page has a list of endorsed aortic centers and doctors. We also have a list. I'm not sure if marfan.org only contains Marfan designated centers, but if you would like to get a list from Aortic Hope, send us a message to info@Aortic Hope, and we'll be sure to email you everything that we have in North Carolina, and also take a look at marfan.org, their list, and see if everybody's included on the list. I really have no idea. Our list includes Marfan designated and non-Marfan designated because it doesn't really matter which hospital you go to. So just check them out. For all I know, they're identical, but they're there. Okay, community member asks about having a 4.2 centimeter aneurysm, ascending aneurysm. This person's 49 years old, healthy, fit, 6'6". Tall person. Doctor said no lifting over 25 pounds. That seems little to me. I'm not a doctor. What do I know? But the doctor said aortic diameter is most directly proportional to your actual height. Taller people have wider aortas. So in a 6'6" man, for instance, 4.2 centimeter aorta is within normal range. Somebody's going to be sleeping really good tonight. I kind of felt like that would be the answer when you're 6'6". I kind of feel like somebody maybe jumped the gun in assuming it was an aneurysm. I think potential dilation at best would have been good, but now I feel like somebody might be able to sleep better, and if need be, go for a third opinion and just wrangle it out between all three. But when you're 6'6", it's normal. So therefore, you should be able to lift anything you want. There's that. All right, we got a question about infection when it comes to artificial valves. This is a pretty serious question because is there a difference? Can somebody have a bacterial infection or is it a viral infection? Like, is there a big infection that you can get or is it little? Is it similar to having a staph infection or like a hangnail? Like, what are we talking about when someone says you might have an infection in your artificial valve? And so the answer says heart valve infections are almost always caused by bacteria or fungi, not a virus. So that's important to know. Any heart valve infection is considered serious because it's hard to get rid of with antibiotics alone. With artificial valves, it's sometimes necessary to do a surgery to remove the valve if it becomes infected. It doesn't matter if the infection is big or small. That's a pretty serious answer to a pretty serious question. So I hope whoever has asked this question, you're having those intense conversations with your personal physicians and making some smart choices. Okay. We are up to when someone is taking a lot of medication to decrease their heart rate and or blood pressure, are we negatively impacting our bodies by trying to work out? Like, is there a preferred exercise? I mean, for me personally, not that this was my question. I know I'm taking a lot of medication right now, more than I was 9 years ago. And even just standing up initially, I got to go slowly. And sometimes walking up a hill or starting to pick up speed or do anything with intensity, I start to feel pressure and discomfort in my chest. I can only attribute it to the fact that my resting heart rate is like 48. So now I'm all of a sudden telling my heart, let's go, let's go. And it's like, what are you doing? Don't do this. The doctor answers and says exercise is so important for aortic health because it decreases blood pressure and actually helps to repair blood vessels. So medications can have an effect on the way that your heart and your blood vessels respond to exercise. Do not decrease the positive benefits of exercise. Let me read that again. Medications can have an effect on the way your heart and blood vessels respond to exercise. They do not decrease the positive benefits of exercise. Any exercise is good as long as you do it consistently. Avoid interval physical straining or intense physical straining, and don't do it to the point of exhaustion. I love that as a general rule of thumb. I know we've all been looking for a general rule of thumb, regardless of situation. And that kind of seems like it because the question did not include if the person was watch and wait or dissection survivor. It was a general question about medication and how it impacts the body. And can you still exercise or are you incurring more stress? And the answer is exercise. Do whatever it is that you feel comfortable doing. You're not hurting yourself with the medication. You're good. I like that. I like it a lot. All right. We're going to refresh and see where else we are. And I'm going to do another promo. Hey, did you guys even look to see that we've got the aortic dissection, the patient guide now in Spanish? Hello. Muy bueno. That's about it. No, I didn't translate the book. It would be very bad if I did. I hope I even said that right. I took 3 years of Spanish. I can't even remember anything. It's so embarrassing. But we did. Like, our team took a lot of time. Hats off to Jenny Schaefer, really, and a couple other people in the community. So many people that really helped with this book in the translating of it from English to Spanish. And it is up. You can download it. You can talk to your physician about ordering a box of 25 in bulk. There is no charge. We don't want any barrier between patient and receiving this incredible resource. You can also order one book as well for your household. And you're going to find that on the main page of our website. You're going to find it under resources. You're going to find it under Hope Shop. You can't miss it because it's in Spanish. So if you want it in Spanish, read the Spanish and click the right button. Or if you want to order in bulk, click the bulk button under the English and there's a Spanish option. So that's exciting. And we're in the throes right now of writing the second book, Aortic Disease, the Patient Guide. Oh, this book takes us through the journey of aortic aneurysms, where they can happen, what zones, since now this organ has zones, where they can happen, how you would diagnose it, what the symptoms would be, what's the treatment options, takes us through aortic stenosis, takes us into aortic regurgitation, bicuspid valve, the symptoms you might feel, the different treatment options, mechanical versus tissue valve. It's going to take us through a couple other things that can impact your aorta, like a penetrating aortic ulcer that might eventually lead to having a repair of your aorta. It touches just a few sentences about dissection because we would refer you to the dissection guide. And it goes into medication and it goes into the types of monitoring tests and diagnostic tests that you can have, like a TEE or transesophageal echocardiogram, an echo, a CAT scan, MRI. It talks about genetics and how this, why, everything. So important to talk to your family about your medical history and think aorta, think family, and talks about resources. So we are pulling all of this together. We're almost at the point of having it clinically reviewed. And then we'll finish up that draft and go right for our endorsement. So that's coming your way. We're hopefully going to see that out in early 2025. All right, time to ask another question and see where we are. Of course, I've got this mousy thing. All right. I'm going to copy this question, stick this up here, and read the new answers. I feel like we're accomplishing a lot, don't you, Joshua? Because we're doing this both ways. We're moving and
It
grooving.
feels like it. We got a lot of
Doesn't
questions
it?
coming in.
It does feel like it. Okay, let's see what new comments we have. One of the things we did recently on Facebook was not horse racing. Let me make sure I explain it correctly. But when the Kentucky Derby happened, we had the community submit names of their horses, like Aortic Thunder or, the Ascending, blah, blah, blah. It was hysterical. Some of these names were great. And then we picked a winner. We did the same for Preakness. And of course, we'll do when the Belmont, right? That's the next one that happens, the last one that happens. So that's a lot of fun. I just happened to see a picture of the trophy and it made me think about it. Okay. Husband had a stable CT in November of 2023. Because of MRI of his back, I guess he had to have an MRI of his back, and another CT due to what the MRI showed, they were told over a week ago that he has a new area of dissection in the right subclavian artery. What concerns should they have? No one seems to want to rush him in to see him. Also, the MRI showed small strokes in his small arteries. Could this be from a new dissection? I didn't even know you could have a stroke in an artery. I don't know what that means. Not even sure. This is going to be one of those kind of challenging questions to answer because it's hard to be very specific on someone's personal case because doctors they don't have a chance to see your scans, et cetera. So generally speaking, the physician said, without commenting on your specific case, dissections of the head and neck arteries are common in people with aortic disease. In those cases, typically physicians would recommend that you consult with a vascular specialist or a neurologist who can review the images and make specific recommendations. And that kind of makes sense. Okay. Okay. We talked about the different test results, talked about AFib. Is there a way to manage your sodium intake during the hotter months? What would be the best practice for this? And the doctor says, actually, sodium or salt intake is not as important as water intake. Drink lots of water, especially when you're going to be outside. Salt just makes you thirstier. So it's not really about salt. I know a lot of people think, eliminate, 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 that's not what you really need to be focusing on. Just focus on your water intake, especially during the warmer months. And I'm sure we're going to hear something very, not very different, but a little different as we get towards the cooler months. Okay. Talked about that. We talked about the infection. Do you ever refer your patients to a mental health specialist when they find out that they might have an aneurysm? Some do. This particular person's does not. I have not really heard anybody doing that. I think that's an awesome decision personally, because I think that we should be referred to them after coming out of having a dissection. Number one, I think that it should be part of our care. I think that we should be required to have our follow up with our primary, have our follow up with the cardiologist. We're going to see the surgeon, and it should be required that we at least meet with a social worker or a therapist. I don't even think that we know that we need to do it. That's how badly we need to do it. For the watch and wait, I kind of feel like if you just got told that you have an aneurysm and now so many things about your life have changed, and when you naturally go home and get on the internet and read that you could maybe die of a dissection or rupture, I kind of think it warrants having a conversation with a therapist or a specialist of health issues to kind of learn how to ground, learn how to regroup, and talk ourselves off the cliff, right? I think that's important. In Dr. Prakash's clinic, though, they screen every patient for mental health issues because it's very common for people to have anxiety and it can affect their physical health. So I'm wondering if that's you know how we all fill out these forms when you go in to see the doctor and it asks the questions, how on a scale of 1 to 5 or 10, have you been feeling depressed? How are you having nightmares? How do you feel at home? Do you feel safe? I wonder if it's something like that, because I do fill those out. I guess I never really gave them that much weight because it's very generalized. But all right, any advice for somebody with only diastolic pressure and unable to take BP medication? No, only high diastolic pressure and unable to take BP medication or like metoprolol. Often this person goes way too low and their pulse pressure is very low, like 12 to 15. Feels terrible when this happens. Okay, doctor says. High diastolic pressure with normal to low systolic pressure is the most frequent pattern in young people that happen to have aortic disease. And generally, it goes away with age without causing any kind of significant health problems. And it'll go away on its own. However, your pulse pressure of 12 to 15 is very low. It sounds like your home blood pressure cuff might not be very accurate. So please ensure that you're using a calibrated arm cuff. Don't use the wrist cuff. Use a calibrated arm cuff that's actually the right size for your arm. And there is information on Validate. I think it's validatebp.org.
I believe
Pretty
it
sure.
is.
Yeah, because that's where you're going to find the validated blood pressure cuffs. They're all going to be listed there. And I believe there should be might be some information there about the proper way to take your blood pressure. But to calibrate it means just take it to your physician, or I wonder if you could take it to like a local patient first or urgent care type scenario and just ask if they could do a quick calibration, because they take all of that in triage. And that would just require you to take your blood pressure, wait 5 minutes, let them take it and see that it's, relatively close. But you might want to have that pulse pressure checked and double check your cuff. Okay. This person says they're 62 and they've had their cuff calibrated. Doctor wants an echo and nuclear stress test. Would there be any other tests that should be considered? Okay, it's been calibrated. Can't wait to see the results to this. All right. What else do we have? Can people ever come off of meds? Are they ever just taken off of meds completely? I wonder, because so many times we take meds and then we feel great and our blood pressure's great. And what happens? Some people decide to stop taking their meds because they're like, I feel great and my blood pressure's great. And I think, well, that's because you're on meds. So why would you come off the meds? Just that makes sense to me. So let's see what the doctor says. Metoprolol is generally prescribed to people with aortic disease to prevent aortic dissection or rupture, and not only for blood pressure. Hear that. When you're put on metoprolol, it's because it's not only impacting your blood pressure, it's to prevent you from having a dissection or a rupture. Okay. There's more than 10 different beta blockers. We just talked about this that you could switch to if you can't tolerate that drug. We just talked talked about that, right? Please talk to your doctor if it's safe for you to decrease or stop that medication, or if there may be other options for you. There's a reason you're on it. Doctors don't just willy-nilly, you hope that they don't just willy-nilly put you on it. There is a specific reason why this particular medication was prescribed. Not everybody who's had a dissection is put on a beta blocker. I know people who weren't. I have to have faith that that was for a reason, right? Mm. Mm. Okay. Let us refresh the screen
So Mindy
and look at
joined
this.
us.
Who did?
Mindy joined us and she said, "Don't add salt at the table."
Don't add salt at the table. Put other herbs, right? Other spices. And drink lots of water. And look at this. This is the Aortic Hope car decal. This is window cling. This is great. If you don't want to put that, if you can't put the magnet on your car because it's not sticking anywhere, you can take this and put it on your window. This is fabulous. And this is for $5 donation. You'll get this. This is also on the Hope Swag order form underneath our Hope Shops. Got to check it out. I put this immediately on my new car. I couldn't help myself. It looks so good on it. I can't stand it. It's great. I'm just saying. And my other car that was burgundy, oh my gosh, my magnet looks so good on it. But the window cling this time, looks so good on it. Just telling you now, I endorse the product. Okay, we're refreshing the screen. Mindy, what would you recommend people can use if you're still here instead of salt during the summer? I'm curious. Don't say garlic because I can't do that. Give me something that would be that would give that flavor, something else that would make it taste maybe salty, but not be salt. Curious. I'm always curious, Joshua. I'm a curious person.
I believe it.
Mm.
Hi, Bruce.
Ruth, hi, Ruth.
No, hi, Bruce.
Hi, Bruce. Hey, Bruce has a fundraiser tomorrow night in St. Charles, Missouri, at the Texas Roadhouse. If anybody's in that area, you need to stop by and say hi. He's gonna have a great table. He loves talking to people. He's so knowledgeable and so passionate about spreading aortic disease awareness. And he may even have like a thing that you can put your name in, and maybe there would be a name pulled out so that somebody could go home with something special. I'm being very particular about my words for a reason, but you should go say hi. Just mentioning that. Okay, let's see.
That's the other Bruce.
Oh, it wasn't the other Bruce.
No, this is Bruce O'Rourke.
Oh, hi, different Bruce.
Hi, other Bruce.
Hi, other Bruce.
He's in the mindfulness course. I'm a fan of Bruce. Bruce is
Oh,
good people.
okay. I didn't. Yeah, no, I did. I haven't met the other Bruce. All right, we've talked about all of these. Let's see. It looks like. Oh, nope. Waiting still for an answer from that one. Playing catch up. Okay, just checking. Why isn't surgery an option when you're not at the 5 or 5.5 centimeter window, but you're healthy for surgery? And maybe you might not be so healthy when it's time for actual surgery. This person understands the risk will always be there, but possibly at a time when we're not so healthy. This question is so good. Thank you, person, for asking it. This is asked so often. People get so frustrated why they just can't say, I elect, I want surgery now. I'm at 4.8. Why do they have to wait until 5 or 5.5? Like this person saying, like now, 4.8, I'm feeling good. I've got stamina. I'm ready to go. You don't know what's going to happen to somebody if they wait till they're like 5.2. So why can't we just do it? And here's the answer why. The decision to have surgery, as far as Dr. Prakash is concerned, and I say this because I've seen and I've heard that different doctors have a different philosophy. So this is one physician's perspective. The decision to have surgery is a shared decision between you and your doctor. The 5 to 5.5 range information is there for general guidance, but should not get in the way of sharing your individual concerns and discussing the risks and benefits. Okay. The decision to operate is very personal. It is. And there's no one answer that should suit everyone when it comes to the risks and benefits of surgery. Now, we know that statistically, it's been said that uh, the chances for having a dissection prior to 5 is lower depending on if you have a known connective tissue disorder or syndrome. So that's part of why I think physicians take that into consideration. But I've always liked this answer that Dr. Prakash says, that it should be a shared joint discussion, talking about pros and cons on why we're still waiting. And can you live with any symptoms you might be feeling while your aneurysm is at the size it's at? You might not be, well, if it's not near your valve, you're probably feeling nothing. But if it is, it could be impacting the valve, vice versa. And it should be a shared decision, right? So if you're at a higher, not like 4.4, probably not going to happen, but if you're higher and you're thinking, let's just do it, talk to your doctor. If you're not happy, you might want to have a second opinion. I don't know. That's up to you. But this is what Dr. Prakash is sharing. Okay. Let's see what else we have. Okay. I'm going to ask another question that just came in. Okay. And yes, I was at first typing all the questions, and I didn't think about copy and paste until you said, "Are you typing all of these?" You could just copy them. Okay, but I didn't really want to copy that one. All right, we just added another great question about cognitive function and would you talk to a neurologist or a psychiatrist? I'm going to put my bet on neurologist. That's where I'm placing my bet, and I am not a doctor. So I, again, cannot wait to hear this answer. And why do I put my bet on a neurologist? Because, and there are cognitive psychiatrists. There's because I've been there personally myself, and I did see a cognitive specialist in a neurology group versus psychiatry because it was more processing information, retaining information, struggling to get words out. These were in my mind nothing to do with any emotional issues, traumatic experiences. Once it was proven to me that my brain was fine, that it actually was tied into anxiety, I then shifted to a therapist who specialized in EMDR, eye movement desensitization and reprocessing, and also worked on coping skills and grounding techniques to alleviate the symptoms of anxiety, because anxiety is a doozy. It's a doozy. It can make you forgetful. It can make you not be able to process your work. It basically mimics everything. So I personally, for me, what I did was started with neurology, but we will hear where the doctor says you should go, because I am not a doctor. I cannot say that enough. I am not a physician, though I like to play one on TV, right? Mm. I am going through my water tonight. My water. What did I just say? My water. I'm going through my water tonight. How's that? All right, let's go check out some more answers. Okay, it is loading. All right, let's see if we've got any more answers to some of your questions. Talked about that one, talked about that one. If you have to have a TVAR, thoracic endovascular valve repair, I can't remember what it stands for. Oh my gosh, it's been a long day. If you have to have a TVAR in your younger age, like in your 20s, let's say, approximately how long will it last until you need it to be revisited? And, what would they do? So this is a valve repair, okay? Bioprosthetic valves from a TVAR. So you're having an endovascular valve replacement with bioprosthetic. Lasts about 12 to 15 years. So that would be your tissue valve. In some cases, they can actually place a second valve over top of that one. So you would have another endovascular repair and they just deploy a second one. They don't have to take the first one out. In many cases, you may need open heart surgery to replace that valve if they can't place another one over the original one. That's one of those things you have to really consider when you're choosing your valve. Because it will last 15 years, if you're 25, you're looking at having another procedure at possibly 40 or sooner. If they can't replace it, now you're going to have open heart surgery. If they can, you're talking about maybe needing to have it looked at again at age 55, or maybe not. It's 2024. Who knows what's going to be around in 2034? I can't believe I'm saying these numbers. God, it's so space age, right? But there's been so many changes just in the last 9 years since I've been in the community. So I'm kind of holding out for when it's my time. That's when I really need to weigh out pros and cons of um, mechanical versus bioprosthetic. Like, how old will I be then? What am I facing time wise? Uh, I'm sure that when the bioprosthetic valves first came out, maybe they didn't know if it would last 12 or 15. I thought it lasted closer to 10. So who knows? But as of today, if you're in that age group, you have to give some consideration to in about 12 to 15 years, could be less. I mean, there's no way to really know, and you might be able to squeak out a few more years. You're going to need to have it replaced. The bottom line is it is not a lifetime solution. It's not. That's something really to think about. Okay. How common is it to have a tricuspid leak? Tricuspid means you still have the three cusps you're supposed to have of your aortic valve. You don't have bicuspid aortic valve disease, which means you were born with two or any other number of cusps. Three is what you want. So how common is it to have a leaky valve or regurgitating valve? This person had open heart surgery a year ago, aortic root ascending aorta replacement, and now has a severe tricuspid leak. So probably when the root or the ascending aneurysm was repaired, they probably did some work, maybe resuspending the valve, maybe not, but you were left with your natural valve and now it's leaking, and now you have severe leak. Um, it was moderate post-op. A few months later, it became severe. This person is managing it now with medicine to try and help, and they're supposed to go for additional testing in 4 weeks. Should the meds not be showing a change or working, what kind of surgery is needed? Okay, the doctor says, let's see, I had it. Okay, doctor says the tricuspid valve can frequently, this is talking about the tricuspid valve, not aortic valve with okay, tricuspid valve, totally different. Tricuspid, um, mitral, aortic. Isn't the other one pulmonary? I can't remember the other valve right now. Begins with a P. Specific to the tricuspid valve, not aortic. The tricuspid valve can frequently be repaired using a tube or a catheter from inside the heart without needing any open heart surgery. So talk to your doctor about the specific type of procedure they're considering doing for you. But he is saying that it often can be done with a catheter or a tube and not even need to have open heart surgery. I totally confused myself on that one. Okay, you can't see this, it's on Facebook, but there was a chart that was depicting height and aorta size, and this community member wanted to know if it was accurate and if it was used in practice. And the answer was there's not really enough available data to be confident that a chart can actually predict an individual's risk to having an aortic dissection. Doesn't matter what information's on the chart. The charts that the physicians typically use are based on large populations of people who have normal aortas or different types of aortic problems and may not apply to everyone. Also, people who have aortic aneurysms might have underlying conditions, and that increases the risk and is independent of height or aortic disease. And that could be people who have Crohn's or lupus or RA or anything else. Height and aortic diameter alone only really account for about half of the total risk on average, and even less than that for most people with an inherited aortic disease. Very interesting. Bottom line, don't look at the charts. Just have the conversation with the physician because the charts cannot be suit everybody's situation. Okay, let's see. In response to the calcium score question, which talked about how the calcium score measures plaque that's in your heart arteries, specifically your coronary, looking for coronary heart disease, anyone with risk factors such as family history of heart attacks, high cholesterol, smoking, high blood pressure, all of those individuals might be told to have a calcium score. The person responded and said that the scores don't really seem accurate in her opinion that she has a friend who has a high calcium score and 0 plaque on surgical exam. And the doctor responded and said it's very common to have a high calcium score without any heart artery blockages at all, because those tests are measuring two different things. All high calcium, all that a high calcium score is telling you is that you're at risk to develop heart artery blockages if you don't make medication or lifestyle changes. It doesn't really correlate to, do you have this plaque? The way you tell if there's plaque is through a catheterization or some other means, because I'm not a doctor and I don't know. But calcium score just tells you the degree of which you're at risk. That's what it means, which I did not know this. I thought it actually told you potential blockage. So this is new information. I love learning something every time. The response from the community member was, thank you so much. Don't the newer lipid tests, size and type and numbers, make calcium scores obsolete? And he said, no, the lipid levels that are in blood are correlated with the chance that coronary artery disease exists, but you still need a separate test to diagnose that you actually have coronary artery disease. This is wonderful. Such great, just such good information. Love it. Okay. See if I missed anything else before I add another one. Okay. No answer came into this.
Hello, Nathan.
Hi, Nathan. Thanks for joining. Let's see. Okay. I think that we've hit all of these questions now. And I'm going to ask this new one that just came in. How is the advancements going for 3D printed aortas? Or how have the success rates been to replace type B? It says sections, I'm assuming. How have the success rates been to replace type B sections? I don't know what that question really means. We'll see if he can figure that out. I apologize for that person's question. I'm not sure what sections means, but I'm going to send it just the way it was written. And we'll see. Okay. All right. So yes, no product placement right this moment. But we do have a live event tomorrow night where I'll be interviewing Dr. Kyle Udaley from University of Alabama, Birmingham. And he's kind of a specialist in this endovascular territory. So I'm really excited to talk with him about some of the latest, greatest things that they're doing endovascularly. What's the population? Like, who is it impacting? Like, why can't somebody with an ascending aneurysm, God darn it, why can't I have an endovascular repair? Why do I have to have open? Like, when does he think that maybe that shift's going to happen? That kind of stuff. I just can't wait. I'm very excited. I do have product placement. I do have something to show you. And that's this. You see this? This is our seatbelt covers. These are phenomenal. These come in different colors, red, yellow, and black, and multiple different sayings. Now, what's interesting is we might have to be making some changes to the pattern and the design, but that's exciting. We love change. But presently, I have plenty on hand right now after making a new shipment order. They come in medic alert, Lowe-Dietz syndrome, vascular Ehlers-Danlos, Marfan syndrome, aortic dissection, thoracic aortic aneurysm, abdominal aortic aneurysm, blood thinners, and pacemakers. If you would like one to be wrapped around your seatbelt or around a dog leash when you're walking the dog or around a bar of your bike, whatever the case may be, these are so easy. They're Velcroed on. They have a place inside to put a card with all of your allergies, surgeries, medical information, prescriptions you're taking. It is so eye-catching. So if you were in an accident or anything should happen, you're incapacitated anywhere, somebody will know that there's something that's really important potentially going on as far as medically related. They are $18 donation and $23 if you are international. So again, Hope Swag order form on our Hope shops. You should check that out. Okay. Okay, so follow up to the first question. Thank you. Sorry, I didn't understand. Totally my fault. I'm adding it. Thank you, though. I appreciate it. That was very quick turnaround, which tells me you're watching, and I love that. All right, let's go and see what other questions and answers we have. Oh, I cannot believe I didn't get a chance to do this mop. just got out of the pool. I don't know. This just didn't make good timing today. All right. In response to the question about cognitive function and should you see a neurologist or a psychiatrist, that was the combo. It's coming. The doctor says a neurologist or a neuropsychologist. There you go, that combo. They administer cognitive function tests and do assessments before recommending follow-up treatments based on the findings. And I did have that test. And it's a long test. Oh my gosh, I've had it done twice. I was so nervous the first time. I'm not going to say anything because I don't want to jinx or interfere with your test, but it was very interesting. I really enjoyed it. I find that stuff very challenging, like to put all these puzzle pieces into holes. Like I forget what the name of that toy was we all played with when we were younger, and then if you didn't get it in time, it all explode. I don't remember, but I like that stuff. Like I like playing Lumosity on my phone. It's free for 3 games a day, and they're really great and mentally challenging. You never know which one is gonna pop up, but they all address different areas of the brain, memory, spatial, all different types of things. Lumosity. If you get a chance, check it out. You can download that app and play 3 games for free a day. So when you go for these cognitive functioning tests, it's very intense. They know what they're looking for. It's a lot of data that they're going to analyze. You have no idea how much that they analyze based on skills tests that you take and memorization games that you play. And the results are simply fascinating. And I honestly was so taken back with my results. That really said I was really smart. I did not expect the really smart part. I just didn't. But in ways that I thought I was failing, that I really wasn't. And it was more of a, if I couldn't remember something instantly, it brought on anxiety, and then the lack of memory became worse, and the whole cycle just kept going. And so speaking with this doctor really just shed a lot of light on my personal situation, and it correlated with the lack of pronounced brain bleeds that I just didn't have any. And so we really talked a lot about pump head, which is discussed in the community a lot. We had a really good conversation about that. And I learned that not everything can be blamed on the fact that we were on heart-lung bypass machines and stuff. Yeah, there's micro bubbles of air in the tubes, but that really wasn't what did it. Or it could have been just the sudden release when you have a dissection. Now, this was really, for me, a lot more anxiety driven. And I learned tools to help overcome some short-term memory issues. And when I did all of that, I really saw major change. And when I started the EMDR therapy and made a medication change, the combination of everything just shifted and really, really, really helped. Okay, let's see what else we got. Ba, ba, ba. Okay. Did that one, we did this one. Just going through to see what we did and we didn't do. Got that one, did that one. We're making good progress here. And let's see. Okay. Here's one. To the point of a question that was asked earlier, with a type A repaired with Dacron graft and a type B medically managed to the iliac with left kidney fed off of a false lumen. Type B is partially thrombosed. Okay. This individual has a wide pulse pressure, 50 to 60s, with average systolic around 115 to 120. Resting and 130 or more when walking. Diastolic is always around 50s to 60s. Any suggestions on how to narrow it? The person went over their medication that they're taking, like 18 of Coreg, 25 of hydrochlorothiazide, 50 of losartan, 10 of amlodipine. Really can't take any more meds because the diastolic drops too much. If fraction rate, or that's heart function rate, is very normal, 65, 67. valve was spared, meaning this person has their natural valve, their native valve. Okay, the answer from the physician is a wide pulse pressure is very common after aortic dissection or graft replacement of the aorta. That simply reflects the stiffening of the arteries after dissection and the Dacron graft. There's very little that you can do to decrease the pulse pressure except by lowering the systolic pressure, which you're already doing with medications. Doesn't sound like this is going to potentially cause a problem, just from what we're reading right there. Okay. Keep going. Keep going. Didn't get an answer for advancement for 3D printed aortas. We're waiting on that.
Hey, Brenny.
Hey, John. La la la.
Bruce says thank you.
You're welcome. You're welcome, Bruce. Okay, gonna go and refresh and hopefully get the answer to this last question or two, because then my time is up with all of you lovely people. And thanks for sticking it out with me. Crazy hair and all. All right, let's see if we've had an update so far. Oh, we do. We have an update to the question about 3D printed aortas. It's a great night. Isn't that exciting? Spending money night. We're going to find out about 3D printed aortas. It's the little things in life. All right. I love 3D printed aortas. I love them. I do. So how is the advancement going for 3D printed aortas, or how have the success rates been to replace type B sections? They're not there. He says we are not there yet for 3D printed aortas. The operative success for type B dissections is good, but they are big operations. And there are other options such as a stent that might be better for certain patients. So I've seen 3D printed aortas. I saw them with my cardiologist at Hopkins.
Yeah, but those are models to practice
Those are
on
models.
versus
Yeah.
versus the
3D
repair.
to go in.
Yeah.
Correct. Yeah, no, they are only using them to make a model to help prepare before surgery. So they wouldn't have time to do that, use a model if it was going to be an emergency. And I don't think they're going to use it if it was, if they could even do 3D printed aorta. You're right. I understand the question now. Modeling for sure, but actual aorta, like you see these things on Grey's Anatomy where they're printing ears or something else and they're sticking them on people. Yeah, like that's not happening yet.
Is that show still like being produced?
Yeah. Hi.
Nice.
I actually sent a message to Shonda Rhimes, shout out Shonda Rhimes, like tag her, because they will do sometimes a relatively okay segment with a dissection patient or a valve patient. Of course, these people wake up after open heart surgery with lipstick and mascara on. That doesn't happen. But I just would like to see a Think Aorta poster scanned in the room, someplace in the ER, someplace, near the operating room. It's not that difficult. I'm not asking for anything that's challenging. Let's give some accurate information and create some awareness around this, not just share it in a dramatic storyline between two doctors who are in a relationship. Let's make some real good positive change. Okay. The success rates in replacing aortas with type B dissections. Will 3D go mainstream? Going back to that changed around question. Most people don't get their aortas replaced after a type B dissection. So we know this is typically managed through medication. Most common options now, at least in the immediate aftermath of a type B, is a stent, TVAR, or medications. That surgery to try to get to that type B is intense and large. So if you can avoid that, you avoid that through endovascular repair, a stent, or just medication therapy. Okay, let's see if there's anything else. I think we got it all. I think I asked all the questions, and I'm pretty sure I've gotten responses to everything. Okay.
I think you did a great job.
Oh my gosh, I might have.
I think it's hilarious that Terry stood you up to go to the gym.
I know, I'm kind of upset. There is one last question in here that was not answered, and I apologize, but you'll have to check on Facebook, and that is about open heart repair and then a TVAR with 10 stents, nearly 4 years out, starting to have shortness of breath and and heart rate fluctuating between 42 and 110 at rest. And they want to know if this could be medication related. So you'll get those answers directly on Facebook. I know I got stood up, but I didn't get stood up by some of the community. You guys were awesome, and I really appreciate you tuning in. And I hope this gave you some really good insight from Dr. Siddharth Prakash. You can find him at UT Houston, University of Texas at Houston. If you would like to reach out to him and you can't find him for some reason, shoot an email over to info@aortic. We'll do our best to get the two of you connected. He'll be at this for at least another 45 minutes on Facebook. I am not going to be at this anymore tonight because I need to get sleep so I can be at it tomorrow night. So I can really ask some great questions. Please join me tomorrow night. Hit that bell, subscribe, get notified before we go live tomorrow, and bring your very poignant questions for Dr. Daly. He's doing some great things over there at UAB. And don't forget to hit like and share. There's some other people out there that are really going to learn something from these live events, and we appreciate it. And we will see you here tomorrow. Thank you, Joshua. Thank you, Dr. Prakash.
Thank you, Dr. Prakash. Thank you, everyone.
Thank you. Have a wonderful evening. Take care.